Buenos días a todos. Muchas gracias por acompañarnos un miércoles más en nuestra sesión académica de pediatría. Mi nombre es Grecia Turrubiates, pediatra y coordinadora de este espacio de educación médica continua. Antes de dar inicio a nuestra sesión del día de hoy, recordarles que para completar nuestra encuesta de satisfacción les compartiremos un link al finalizar la sesión. Y además, si quieren que reciban la invitación a nuestra sesión, lo pueden solicitar en este correo que les aparecemos a continuación. Además, cualquier pregunta que ustedes tengan la podrán realizar en nuestro chat y se la haremos llegar a nuestra ponente del día de hoy al finalizar la sesión. En nombre de la Escuela de Medicina y Ciencias de la Salud, les damos la más cordial bienvenida a la sesión académica de pediatría. El día de hoy tenemos nuestra tercera sesión del mes de agosto, que como ya saben, tomamos el tema central de la primera infancia, para lo cual agradezco a todo el equipo del Centro de la Primera Infancia por hacer posible la organización de este mes. Para presentar a nuestra ponente del día de hoy, le doy la palabra al doctor Juan Francisco Lozano, quien es profesor de cátedra de nuestro posgrado y además es el director del Centro Órbita, además de, por supuesto, parte del equipo del Centro de la Primera Infancia y del Tecnológico de Monterrey. Muchas gracias, doctor Lozano, por ser parte de este mes y adelante, por favor.
Muchas gracias, Grecia. Y bueno, voy a cambiar a inglés para poder introducir a la doctora Stamatakos. Muchas gracias. Thank you, Maria, for having us. It's a great pleasure for me to introduce Dr. Stamatakos, who I had the pleasure of having her for a short while, but as a trainee, I was there with her. So Dr. Stamatakos is trained as a pediatrician. She's a board certified in general psychiatry and child and adolescent psychiatry. She's an associate professor of child and adolescent psychiatry at Nationwide Children's Hospital and Ohio State University Wexner Medical Center. She serves as the medical director of the Early Childhood Mental Health Program, which is a comprehensive initiative that partnerships with Head Start programs, which is specialized in clinical care and interagency therapeutic interventions. Her clinical academic career spans over a decade with a focus on early childhood development and therapeutic interventions for young children. To highlight, Dr. Stamatakos is the recipient of the Passion Award from the American Academy of Child and Adolescent Psychiatry on Child Maltreatment and Violence Committee, which recognizes her commitment to vulnerable children. She also actively engages in statewide initiatives to strengthen early childhood mental health systems in Ohio. And she leads a 15-session didactic program with the Psychiatry Fellowship. So, Dr. Stamatakos, thank you so much for having the time to spend with us for our pediatric specialist here in Monterrey.
Thank you for having me. Let me make sure that I've got the slides up. We good?
Here we
Okay,
go. All right.
perfect. So uh, um, as you talked about, I am fortunate enough to work at Nationwide Children's, where we really have seen a commitment to early childhood mental health and early childhood development. So my presentation today is about the effects of trauma on early childhood development. So disclosures of potential conflicts, well, none. I haven't really done anything. I've been dodging presentations for 20 years, and you caught me. But this is important, and when I was asked, I felt really compelled to say, we need to talk about this. So this is the why. Why are we even talking about trauma that happens before these babies can talk? They won't remember. If it didn't directly involve the kid, it's fine, right? They'll just grow out of it. Parents might say, It happened to me when I was little too, and I'm fine. And this is the why. A brain developed in trauma looks different than a typically developing brain. There are brain changes that cause long-term impairment. And the early identification of trauma and traumatic stress is imperative to changing a child's developmental trajectory and mitigating future mental illness. So our learning objectives. We want to highlight the importance of the caregiving relationship to brain development. We want to identify the negative effects of early relationship disruptions and trauma on development. Recognize the characteristics of dyads that are at higher risk for disrupted attachment. Identify behaviors of children who have experienced early childhood trauma or relationship disruptions. First, we have to talk about ACEs, adverse childhood experiences. In my opinion, this more than anything else has given validity to the importance of prevention, identification, and treatment of childhood trauma. The groundbreaking study published in 1998 by Vince Folletti demonstrated a graded relationship between exposure to abuse, neglect, and household dysfunction during childhood and multiple risk factors for several of the leading causes of death in the United States: heart disease, diabetes, obesity, substance abuse, nicotine use. The number of ACEs also contributes to other areas of morbidity that are at a cost to the individual and community, such as poor academic achievement and time out of work. Not every ACE is traumatic. An ACE becomes traumatic if it poses a threat and overwhelms the child's developmental capacity for coping at the time of the event. What are the factors that make an event traumatic? Well, the severity of the event, proximity to the event. Was the child the victim? Did the incident occur in the presence of the child? Did the child experience the aftermath of the event? Or was the child told about the event after it occurred? Caregivers' reactions. Was the child believed and validated? Did the caregivers demonstrate the ability to provide stabilization in the environment? Did the caregivers demonstrate their own self-regulation skills, or was the caregiver's reaction just as scary? Prior history of trauma. Children continually exposed to traumatic events are more likely to develop traumatic stress reactions. Family and community factors. Culture, race, and ethnicity of the children and their families can perpetuate harm or be a protective factor. According to the National Child Traumatic Stress Network, a traumatic event is a frightening, dangerous, or violent event that poses a threat to a child's life or bodily integrity. Witnessing a traumatic event that threatens the life or physical security of a loved one can also be traumatic. This is particularly important for young children, as their sense of safety depends on the perceived safety of their attachment figures. NCTSN lists several types of trauma. Ones often seen in my practice are physical harm, sexual and psychological abuse, neglect, family or community violence, caregiver substance or alcohol abuse, sudden or violent loss of a caregiver, and traumatic separation. When talking about ACEs and trauma, it's also important to understand the impact of stress. Positive stress is essential for healthy development. It is brief, and when in the context of a supportive relationship, the physiological response is limited and returns to normal quickly, fostering the development of a healthy stress response. Examples would be the first day of school, making and meeting new friends, a family wedding, or worse, being forced to walk down the aisle for a family wedding with a whole bunch of strangers who are much bigger than you watching you. If the child is engaged in a loving, predictable, and supportive relationship with a consistent caregiver, the caregiver scaffolds the child's experience, allowing a sufficient amount of challenge or stress in order to promote a reaction, but not so much that the child is not able to return back to their steady state. Tolerable stress. Tolerable stress is more severe, longer lasting reactions that activate the body's stress response to a greater degree. But if the stress is time limited and buffered with relationships with adults who can help the child adapt, the brain can recover. So examples would be surviving a natural disaster or death of a family member. Toxic stress is strong, frequent, prolonged adversity without sufficiently supportive relationships to buffer against the stress. Chronic abuse or neglect, ongoing parental mental illness or substance abuse, extreme poverty, persistent exposure to domestic violence. This is the kind of stress that negatively affects brain development. The National Council on the Developing Child recognized that the body stress response does not distinguish between threats. It just recognizes that there is a threat. So the infant or young child will experience the same physiological stress response with an episode of physical abuse as the child with food insecurity or prolonged neglect. And so the council coined the term toxic stress to describe the effects of extensive activation of the stress response system on a child's developing brain, immune system, cardiovascular system, and metabolism. This is the type of stress that impairs the development of neuronal connections in the areas of the brain dedicated to more complex skills like language, attention, and decision making. We know that genes provide the blueprint for the formation of brain circuits. Simple neuronal connections form first, followed by more complex connections that are influenced and reinforced by experience. Reciprocal interactions between the primary caregiver and the infant are the experience that strengthen these circuits using neuronal pruning and myelination. The idea of you use it or you lose it. Literally, emotional experiences become embedded in the architecture of the brain, and a healthy brain depends on a foundation built with stable, consistent, and predictable interactions with a primary caregiver. The development of emotion and cognition relies on the emergence, maturation, and interconnection of complex neural circuits in multiple areas of the brain, including the prefrontal cortex, the limbic cortex, basal forebrain, amygdala, hypothalamus, and brainstem. These circuits are involved in the regulation of emotion, are highly interactive with the areas of the brain that are associated with the executive functions, such as planning, judgment, and decision making. This interaction affects the development of problem-solving skills during preschool. And then later, these same circuits will affect the emotional and social abilities important for the formation of lasting friendships and intimate relationships. Also, things like effective parenting, maintaining successful employment, and engaging appropriately within a society. The goal of this slide is simply to show that skills are the result of relationships that influence the development of the structure of the brain and impact future development. When this works well, infants learn how to respond in times of distress. The consistent presence and predictable response of the primary caregiver increases the infant's capacity for self-regulation. Inconsistent, harmful, or the absence of a response to the child not only deprives the brain of positive stimulation, but also triggers the same toxic flooding that the same toxic response flooding the developing. Let's try it again. It triggers the same toxic response that then floods the developing brain with stress hormones. When a child experiences trauma or toxic stress, the sympathetic nervous system responds by releasing increased levels of the brain's major stress hormone, the corticotropin releasing hormone, which regulates the release of catecholamines, resulting in a hyper metabolic state and hyperarousal. In this state, Energy stores are mobilized, immune responses are activated, and certain types of memory are enhanced. Hyperarousal is also associated with the hyperactivation of the N-methyl-D aspartate sensitive glutamate receptor, or the NMDA receptor, which is the central site of neurotoxicity and synapse elimination in early brain development. In cases of severe chronic abuse, especially during early sensitive periods of brain development, the regions of the brain involved in fear, anxiety, and impulsive responses overproduce neural connections, while those regions dedicated to reasoning, planning, and behavioral control may produce fewer connections. Again, that idea of use it or lose it. Then, post-hyperarousal, the infant enters into a primary parasympathetic mediated metabolic shutdown, where little energy is available for growth because all of their resources are going towards reorganization. Chronic hypometabolic modes can have devastating effects on the morphogenesis of the limbic structures. If repeated and chronic, this cycle can negatively affect myelination and change the connections in the temporal lobe, essential for learning and memory. PET scans demonstrate how these repeated and chronic stressors change the hippocampus of the temporal lobe. It can be a pretty marked difference. So, the Center on the Developing Child from Harvard University is an amazing resource for slides for teaching in the future. It is just such a helpful resource. But this slide demonstrates how trauma occurring during developmentally sensitive times can affect skill acquisition necessary for further learning and function. You can see how energy and resources diverted towards reorganization versus growth, especially during the first 3 years of life, can have lasting effects on language development and higher cognitive functions. We can actually see measurable changes in cognitive development. This data is from the Therapeutic Interagency Program at Cincinnati Children's Hospital Medical Center. TIP is a treatment model developed by Jane Seitz. It involves providing behavioral health services in a preschool setting. These children all have trauma-related diagnoses and have behaviors that make it difficult for them to be maintained in a typical preschool setting. After TIP started offering ancillary clinical services, they found that 80% of their students required interventions. 70% required, 80% required speech interventions. 70% required occupational therapy interventions. And also of note, 25% of these children required individual education interventions in the classroom setting, moving into kindergarten. In our early childhood program at Nationwide Children's Hospital, we incorporate speech and occupational therapy evaluations as part of our integrated assessment for children under the age of 6. Of the 711 children who presented for an initial evaluation for a variety of complaints, so they're coming in for inattention, hyperactivity, aggression, temper tantrums, 63% required speech and OT evaluations for treatment. So, if we separate out the number of children who met criteria for trauma-related diagnoses, so PTSD, trauma and stressor-related disorder, acute stress disorder, 71% of those children required speech and OT. So these early findings are similar to the results published by TIP at Cincinnati Children's Hospital Medical Center. We see the evidence of the ongoing negative effects of traumatic stress and trauma exposure past the preschool years. We know they have difficulty in relationships. We see increased mental health diagnoses and lethality, child welfare involvement and out-of-home placements, academic failure, economic adversity, substance and alcohol abuse disorders, and involvement in the juvenile justice system. One example of these long-standing effects is the preschool to prison pipeline. The preschool to prison pipeline refers to the tendency of minors and young adults from disadvantaged backgrounds to become incarcerated because of harsh school and municipal practices. We already know that children from adversity, children with the history of multiple ACEs and trauma, have poor emotional and behavioral regulation, and that there is a high likelihood that they are also experiencing developmental delays as well. And so when academic and social demands are placed on these children, many of them will respond with externalizing and disruptive behaviors. Educators with limited support and training on how to manage these children often utilize exclusionary practices, so removal from the classroom, in-school suspensions, out-of-school suspensions, and expulsions. Time away from the classroom increases the rate of dropout, and once a child drops out of school, the risk of incarceration increases by 40%. But the negative impact of trauma doesn't end with the individual. Alicia Lieberman and Patricia Van Horn appropriately observed that the intergenerational transmission of trauma and disorganized attachment may well happen at the neural level, as children traumatized in their attachment relationships grow into adults whose brain structure is ill-equipped to support an empathic response to their children. We know this to be true because of epigenetics, demonstrating inherited changes on the genetic level without actually changing the genetic code. Environmental factors, including stress, activate proteins that determine whether a gene is turned on or off. Then these genes are passed on to the next generation. Hopefully, I've made the case for the importance of relationship in early childhood development and the possible outcomes that might result if these attachment relationships and trauma are not recognized and mitigated. How do we recognize dyads that are at risk in infancy and early childhood? We think about red flags that can potentially create a situation of poor attachment and should alert the physician to the possibility that the child may be at risk. Things like caregiver mental illness or substance abuse, separation from the caregiver, interpersonal violence, caregiver trauma or multi-generational trauma, medically involved children, and extreme poverty. It is extremely important for us to be aware of these risk factors because dyads are presenting in primary care offices before they're going to present to behavioral health, especially in the first 2 years of life. This image was borrowed from an article in the New York Times. One area where pediatricians can intervene is the area of postpartum depression. It occurs in approximately 10 to 15% of women. It's considered a risk factor for a range of negative cognitive and social emotional outcomes in young children, including disturbed attachment. This has been demonstrated by following a large sample of children from birth whose mothers were diagnosed with depression. Because these women present regularly to primary care during the first 6 months of their baby's life, it is an important opportunity to screen and make appropriate referrals at a time early enough to decrease the likelihood that disordered attachment will develop. Some examples of validated screening tools are the Patient Health Questionnaire 9 or PHQ-9 or the Edinburgh Postpartum Depression Screener. Both are free and easily interpreted. According to 0 to 3, almost 19% of all infants experience at least one ACE. So how do infants who are presenting with chronic toxic stress or trauma present? With disturbances in their rhythm, so eating or sleeping disturbances, failure to thrive, lack of responsiveness, increased separation anxiety, inconsolable crying, developmental regression, or loss of playfulness. In preschool children, many of the symptoms are similar, but because of their developmental capacity, preschool children specifically may lose recently developmentally acquired milestones or regress to simpler speech. They may become clingier to their parents or worry about their parents' safety in return. These young children may also become more irritable with increased frequency of temper tantrums and have more difficulty calming down once escalated. Or they might show the reverse behavior, become very withdrawn, subdued, or even mute after a traumatic event. Preschoolers may have difficulty falling or staying asleep. They may experience nightmares about the event or other bad dreams. And typically, these children will process the event through post-traumatic play and reenacting, trying to gain mastery of a situation they don't understand. So, not an all-inclusive list, but there are some key behaviors that might make you think about a child's exposure to violence. Imitative physical aggression. So, actions you wouldn't expect a child of that age to know about. Choking, threatening with weapons, using threatening language, behaviors that suggest exposure to that type of violence. These children will typically identify with the aggressor. I see a strong figure hit and hurt my caregiver. I can either be scared and get hurt like my caregiver, or I can be strong like the aggressor. So you will start to see these kids aggressively target caregivers and their siblings using the same language and aggression they have witnessed. Aggression that involves coercion. If you don't play with me, I will. If you don't give me your doll, I will. Aggression that occurs in secret, as opposed to impulsive or reactive aggression of early childhood, when a child hits because they don't have the ability to communicate their frustration. This aggression occurs in a planful way, out of sight from authority figures. The purposeful targeting or bullying of a specific child, and evidence of torture. Again, not an all-inclusive list, but just to think about some indicators of neglect. Some physical indicators would be chronic uncleanliness or poor hygiene, untreated illness or injury, unsuitable clothing for the season, so missing key articles of clothing like socks or shoes or coats in the cold. Height and weight significantly below age level or meeting criteria for failure to thrive. Some behavioral indicators are chronic hunger, begging or scavenging for food, eating past satiety, chronic fatigue because of erratic sleep schedules, frequent absences from school, tardiness or coming to school early or leaving late, and assuming adult responsibilities. Indicators of physical abuse. So the child's disclosure, injuries that are at various stages of healing, conflicting stories or explanations of the injury between caregivers with each other or with the child, injuries that don't match the story or developmental stage, so transverse fractures of long bones in an infant with limited mobility, burns, scarring, scalding, marks that don't make sense developmentally or functionally, like choking marks around the neck, handprints, marks in the shape of an object used for corporal punishment. The child's behavior around their caregiver. Remember, in early childhood, a safe, predictable, and consistent caregiver should offer a child a sense of security. So suspicion should be raised when a child cries or refuses to engage that caregiver. Something else to keep in mind is that caregivers will keep kids out of daycare or school until the physical evidence of abuse is no longer visible. Indicators of sexual abuse. So physical indicators, it's normal to be normal. Often there's no physical evidence of sexual abuse because that area of the body heals so quickly. Potentially, you may have sexually transmitted infections, injury, and physical discomfort. However, sexualized play or behaviors, as well as preoccupation with sex in this age group, should raise suspicions. Sexual behaviors are concerning if the behaviors are identified beyond the child's developmental age or capacity, if they involve children of significantly different ages or ability, if the play or behavior provokes strong emotional reactions in the child, like anger, anxiety, or dissociation. If the play is preoccupying or it is difficult to distract the child from engaging in the behavior, the child may become frustrated or angry when redirected from the behavior. If the behavior interferes with social development, or sexual behaviors involving aggression, coercion, threats, force, or intimidation. So children at risk who've experienced trauma or toxic stress are hidden in plain sight. So how do we identify these children when it's normal to be normal? We ask the questions and we screen. The American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, the National Child Traumatic Stress Network, and 0 to 3 all have recommendations for screening for trauma in at-risk dyads. The National Traumatic Stress Network recommends that trauma screening is administered to every child in every system. Screening can be as simple as a couple of questions in a clinical interview. Has your child ever been exposed to something scary or frightening for a child of his or her age? Has your child ever been separated from you or other caregivers for a period of time or experienced a loss? The American Academy of Pediatrics clinical report dated July 2024, titled The Pediatrician's Role in Preventing Maltreatment, outlines recommendations including the assessment of risks and resilience during any contact with the child. Risks and protective factors for child maltreatment potentially occur at the level of the child, the family, the community, and society. The Pediatric Intake Form and Bright Futures Health Supervision Guidelines from the American Academy of Pediatrics, also known as the Family Psychosocial Screen, provides one blueprint for assessing family functioning. Another way, although somewhat controversial, is to screen for parent trauma by collecting the ACEs of the parent or caregiver. Although there is no specific recommendations using caregiver ACEs for screening or treatment recommendations, caregiver ACE scores give the provider an idea of the complexity of the impact of trauma on the family system and some insights into the caregiver's response to their child's trauma-related symptoms. Using a universal approach to screening can help lessen family concerns about stigma. The American Academy of Child and Adolescent Psychiatry recommends the psychiatric assessment of children and adolescents should routinely include questions about traumatic exposures and PTSD symptoms. This can be done by clinical interview, or it can be done by validated screening tools, many of which are easy to use and without additional cost. Also, many of these screening tools have been translated into Spanish. Also from the American Academy of Pediatrics Clinical Report on Intimate Partner Violence, the Role of the Pediatrician, dated June 2023, it addresses the concerns for screening for intimate partner violence. It recommends using the Universal Education and Resource Provision model, where the clinician provides information about what intimate partner violence looks like and makes resources available for assistance and support. Recommendations include screening in multiple settings, like the birth hospital, primary care, inpatient units, subspecialty clinics, using either the Universal Education and Resource Provision model or validated screening tools. The Universal Education and Resource Provision model has also been shown effective in school-based health care centers, college-based health centers, family planning clinics, and emergency departments. Screening tools are also acceptable, either electronic or in paper form, because it is more likely that a caregiver will fill out a tool more honestly in electronic or paper form versus being asked directly in a clinical interview. From this same report, there is a list of potential models and screening instruments that has been made available by the American Academy of Pediatrics for the screening of interpersonal violence. So we identify the ACEs and trauma and attachment disruptions and chronic toxic stress. What can we do about it? The answer is multifactorial. It involves prevention, involvement in evidence-based therapeutic interventions, at times medication management, education for families and care providers, access to educational supports such as individual education plans, including speech and occupational therapy interventions, resources in the community to facilitate access to care and relieve issues related to poverty. The American Academy of Pediatrics has identified areas of prevention supported by research. Anticipatory guidance focusing on normal development and developmental expectations. Home visiting programs that are well researched that target child maltreatment prevention, including nurse-family partnership, Child First, and Healthy Families America. Early education programs such as Head Start and Early Head Start. Positive parenting programs that increase caregiver skill sets, like Triple P or Incredible Years. Socioeconomic support of families in need, like paid parental leave, supplemental nutrition assistance programs, and subsidized medical insurance. Recommendation for the prevention of sexual abuse specifically includes early and repeated education about body safety and teaching caregivers how to talk to their children about body safety. Educational programs that raise awareness and intervene in situations where the risk of child abuse is high. Increased supervision of older children with younger children, and more stringent background checks on everyone who works with children. This is a list of evidence-based treatment modalities on the National Child Traumatic Stress Network website. In our early childhood mental health program at Nationwide Children's Hospital, our clinicians are trained to fidelity in child-parent psychotherapy, perinatal child-parent psychotherapy, trauma-focused cognitive behavioral therapy, circle of security, and trauma-informed interventions focusing on the development of parenting skills, such as child-adult relationship enhancement and parent-child interaction therapy. When we look at all of these treatment modalities, there are identified core components of effective trauma treatment. The active involvement of a caregiver. It enables the caregiver to understand the child's response and respond to the child appropriately. It also enables the child and parent to share perspectives about what happened, their fears, their attributions, and their cognitive distortions. Psychoeducation about trauma symptoms that helps the caregiver and child understand what is happening and why. It helps normalize the child's experience in that the child is reacting in a normal, predictable way to something abnormal or something that shouldn't have happened. The enhancement of emotional regulation and anxiety management skills. It's a fancy way of saying learning the development of coping skills. Addressing the child and family's traumatic stress reactions and experiences. Providing the opportunity to process what happened in the safety of a therapeutic setting, usually in some sort of narrative form, telling or drawing the story, retelling in play scenarios. And then finally, because these children are at higher risk for re-victimization, relapse prevention, and future planning. Medication is one potential tool that might be helpful in the treatment of early childhood trauma in the context of participation in an evidence-based therapeutic intervention. And we've ruled out non-psychiatric medical causes of a child's presentation, like things like thyroid disease, seizures if we're looking at dissociative episodes, blood sugar abnormalities, through careful history taking, clinical exam, and further medical testing if indicated. We ensure that the symptoms are occurring in two different environments, that the behaviors are not occurring in the context of a single relationship. When we do talk about medication management, we want to think specifically about the goal of treatment. We want to target symptoms including emotional hyperarousal, irritability, anger outbursts, poor concentration, and erratic sleep. Overall, the goal is to restore function, allow developmental progression, and increase the child's capacity for psychotherapeutic management of trauma-related material. We always want to minimize the potential of adverse effects because remember, we still don't know the long-term impact of treatment on the developing brain. So since we have a couple extra minutes, I also included a case example that I recently saw this past year to kind of illustrate some of the principles we talked about. Mom brings in a 4-year-old child after the unexpected death of his father last year, about the same time. She notes some difficulty with sleep onset and maintenance, as well as secondary nocturnal enuresis over the past month. Associated symptoms include preoccupation with death and fear of dying, anger outbursts, fear of social situations, unfamiliar situations, and unfamiliar people. He refuses to be alone anywhere without his mother and talks about recurrent memories of his father. Mother describes episodes that sound like dissociation. He talks about his father's death, will sometimes call after him and talk about him like he's still alive and search for his dad throughout the house, while alternatively at other times saying his dad is dead without emotion, with indifference. He appears hypervigilant to mom. This little guy was born to a 43-year-old female with an uncomplicated pregnancy and delivery. He was the result of an extramarital affair, and father ended the relationship as soon as he found out about the pregnancy. Mother was thrilled because she didn't think she would have the opportunity to have a second child. During his first year of life, father would visit in mother's home, but after patient stopped breastfeeding and father moved to another state, he started visiting father for 1 weekend a month. No difficulty with transition to visits or back from visits. By the age of 2, father was brought back to the state because of federal legal charges. Right before the age of 3, father completed suicide. The child did not attend the funeral proceedings because there were members of paternal family that did not know about the patient's existence. He is in a private school and at preschool and has difficulty speaking in class, but that's improving. He engages in parallel play but struggles with participating in reciprocal play in an ongoing way. Family history of anxiety, ADHD, and now completed suicide. He was evaluated by our developmental and behavioral pediatrics department and did not meet criteria for autism spectrum disorder. He is in speech pathology for delayed receptive and expressive language, and occupational therapy was not indicated. On exam, he engages pretty easily. He's playful, but will follow mom from room to room. He's eager to show this provider his toys. I neglected to mention we were doing this visit virtually. But he would show me his toys and playfully would catch a bubble in his mouth when you would ask him any questions. He was diagnosed with trauma and stressor-related disorder. I referred to child-parent psychotherapy, which is an evidence-based dyadic treatment for young children with a history of trauma or disruptions in their primary attachment relationship. He utilized play to process the traumatic history in the context of the dyadic relationship with his mother. His medical workup, including TSH, vitamin D, ferritin, CMP, or renal, and an EEG to rule out seizure activity, all were unremarkable. And we started guanfacine, an alpha agonist that I used to decrease the physiological response to trauma. The patient has done well. He's demonstrated increased ability to verbally process the loss of his father and should have started kindergarten here in the past week. So in summary, early childhood maltreatment and traumatic stress have lasting effects on development and remain notable throughout childhood. Everyone who comes into contact with children needs to screen. Clinical questions, education, and access to resources or validated screening tools. There are evidence-based treatments. We just need to identify the kids. And as always in mental health, we need more people doing this work in the workforce. So those are my references. And I wanted to thank Dr. David Axelson, who's the chief of our nationwide children's hospital, psychiatry and behavioral health, who has been a huge advocate of early childhood mental health. Nadine Schwartz, who's been a mentor, Maggie Good, who helped me design the slides, a number of people who painfully sat through practice sessions and gave me feedback. And of course, Doctors Lozano Ramirez, this I might butcher, Turbiades Hernandez, and Lilia Guzman Acevedo, and the Center de Primera Infancia, the School of Medicine and Health Sciences at the Tecnológico de Monterrey, for the invitation and opportunity to be part of such a discussion about such an important topic.
Wow. Thank you, Maria. This was just a definitely good interview. Exposure of everything that the focus of this month has been about early childhood. We definitely, as part of the center, we focus a lot of our research on adverse childhood experiences, also the positive or benevolent childhood experiences. So, talking also about, yes, all of this happens, that it's kind of negative for the child and the family. Also seeing this light of hope that we can do all of this and help the families and the children especially. It's very important for pediatricians to know that we need to be looking into this for a healthy development in general for children. Now we have a couple of questions, and I think they are definitely good. So the first one is, so understanding that children and adolescents who have experienced adverse events are at risk of developing various physical and mental health conditions. What recommendations can you give us so that as healthcare professionals and as a society or community, we can avoid labeling or pathologizing these children?
So I think, I mean, I don't know that there's tons of research behind my answer, but I think part of stigma and pathologizing is secret, right? We all these things are occurring in the dark. Nobody talks about them, and I think the more we screen, the more we educate providers, patients, families, teachers, that these things do occur and have occurred and are not a reflection of the child, but what happened to the child. I think they're slowly over time, there'll be less pathologizing of the child.
Right. Yeah, I totally I agree. It's just starting the conversation. I think that's the part of building this rapport in the families and getting aside of the labeling and stigma as you mentioned. Now, is there an age at which a children is at greater risk of like permanent harm as a result of an adverse childhood experience?
So that is a particular answer I don't know. What we do know is that the earlier the traumatic event or the chronic toxic stress happens, especially during the first 3 years of life, where there is so much brain development and connection and you know all the plasticity. It can be more it it can deter the trajectory much more than a little bit later when there isn't as much brain plasticity. Alternatively, though, theoretically, you would think that, and this is what I totally believe, and many of us as early child healthcare providers believe that this is a time where the brain is plastic and there's so many connections, and kids can, you can look at a brain in an MRI and see one thing, and then look at the child and they look completely different. And so I think it's important to we know about the adverse experience or the event, and we treat as early and as fully as we possibly can, giving them every opportunity to develop new connections.
Yeah, definitely. Now, a little bit into, I know you talked about kind of there's different evidence therapies and treatments that are there. But I mean, what type of therapies, what do you think about cognitive behavioral therapy, dialectic behavioral therapy, EMDR, a little bit of standpoint of if you had to choose one type of therapy in a setting where there's limited resources, I mean, what is a little bit more, I don't know, easier to find or that you can provide
Right.
for the family?
So in that case, when we think about, right, like when the babies are little, or under the age of 1 or under the age of 3, like they really cannot exist without their primary caregiver, right? So if I had many of our like more manualized therapies like dialectical behavioral therapy, cognitive behavioral therapy, are very language based, and your patient, the child, then will miss out. Like if they can't play, if we can't use their play to interpret their experience, like they're not going to benefit from a language-based therapy. However, if we're thinking about the dyad as our patient and multi-generational trauma, then my focus would be, can I get parent into an appropriate treatment modality that will help that parent process their trauma and develop skills in order to be an effective parent, such as dialectical behavioral therapy or trauma-focused cognitive behavioral therapy. So we can work on maternal health in order to help the young child become more stable in their emotional connection and development with mom, the
Right.
caregiver.
Yeah,
Doesn't have to be
that
mom.
definitely, yes, definitely answers the question. Um, in an environment where adverse events for a child, what is the evidence available between what's better for the child uh, being in foster care versus working with the child and the parents trying to, rebuild what is happening around this child maltreatment, negligence. Is there any evidence of one system working better for a child?
Not that I know of, and this is a question that is incredibly controversial, right? Because even removal of the child from their primary caregivers is considered an adverse childhood experience. So, how do you pick one over the others? But we do know that cumulatively, the number of ACEs affect their long-term development and affect their physical health. And so, while the goal often is reunification, sometimes that initial environment cannot sustain a healthy, predictable, consistent relationship and safe environment so that the ACEs don't continue to occur.
Understand. And
Oh, you froze.
I know you connection is weird. A lot of wind outside. I apologize. But one question says you presented some questionnaires,
Mhm.
screeners we can use in primary care. Is there like one that you particularly questions to this
Sorry, you're breaking up.
screener that you recommend for pediatrician?
The
Like,
question, yeah, like if you will recommend one over all the others for us general pediatricians to use in
so,
your office.
um, So I have favorites, but all of them, like if um, they've been vetted and supported by the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics. So it's you look at time and your comfort in administrating the questions that are asked. I particularly like to use the Edinburgh postpartum depression scale for early presentations, mom and baby. And later on, we tend to use in our clinic, we use the we use eight or the pearls, which includes also the ACEs and the social determinants of health, and the PC-17 preschool, which is it's a questionnaire that looks through kind of all types of symptoms it screens, but asks particularly about trauma, anxiety, depression, because that is what is in line with the rest of our hospital, and that is being administered throughout, so that consistently answers in the pediatric, in our pediatric clinics can be compared to neurology, can be compared to um, psychiatry.
Perfect, doctor. Thank you so much. Those are all the questions.
Okay.
So, thanks again for taking time and sharing your knowledge with us. I'm confident that this shared knowledge will be very helpful for our pediatricians and our patients.
Thank you so much for
Okay,
having
thank you.
me.
No, no, thank you for accepting the invitation. So, I will be switching to Spanish if that's okay with you. Gracias a todos por acompañarnos un miércoles más. Nos vemos la próxima semana con nuestra última sesión del mes.